Drug distribution, why it matters. Welcome to PharmaconHealth. In this video, we explore a vital topic in pharmacokinetics: drug distribution. You'll learn how it influences onset, intensity, duration of action, and why it plays a central role in drug therapy success. Now, let's begin by understanding what drug distribution really means. Definition: drug distribution refers to the process by which a drug moves from the bloodstream, also called systemic circulation, into the various tissues and fluids throughout the body. This occurs after the drug is absorbed or administered directly into circulation. This movement is not uniform. It depends on factors such as the drug's chemical properties, capillary structure, biological barriers, and how the drug interacts with proteins and tissues. Having defined the concept, let's now explore why it is so significant in clinical practice. Significance: understanding how a drug is distributed in the body is crucial. It determines how much of the drug reaches its target, how fast it acts, how long it stays effective, and whether it accumulates in tissues. Each of these factors affects patient response in clinical decision-making. Let's first look at how distribution affects the onset of a drug's action. The onset of action: this refers to how quickly the drug begins to produce a measurable effect. Once in the bloodstream, the drug must travel to its target, for example, the brain for seizures, or lungs for asthma. The faster it reaches the site, the faster the effect. Examples: intravenous fentanyl distributes rapidly to the brain, gives pain relief within seconds. Oral ibuprofen, though quickly absorbed, takes time to distribute, gives slower onset. Distribution speed controls how rapidly a drug begins working, critical in emergencies. Next, let's consider how distribution affects the intensity of the drug's effect. The intensity of action: this means the strength or magnitude of the drug's effect at its target site. It depends on the concentration of active, free drug at the site. If distribution favors delivery, more drug binds to receptors, gives stronger effect. But if most of the drug binds to plasma proteins or poorly penetrates tissue, the effect weakens. Examples: phenytoin is highly protein-bound, gives less free drug, gives reduced effect. In hypoalbuminemia, free drug increases, gives possibly stronger or toxic effects. Distribution determines how much drug is available to act on its target. Now let's move on to the duration: how long the drug remains effective. The duration of action: this refers to how long the drug remains effective in the body. Drugs stored in fat or muscle act like reservoirs, slowly releasing the drug even after plasma levels fall. Drugs that stay in blood may be eliminated faster and wear off sooner. Examples: diazepam, which enters fat and muscle, causes prolonged sedation. Esmolol remains in plasma and is cleared rapidly, gives short effect. Distribution affects how long a single dose stays therapeutically active. Now, let's examine the balance between plasma levels and tissue penetration. Plasma versus tissue levels and site-specific efficacy: different tissues receive different drug amounts based on blood flow, membrane barriers, and capillary structure. Drugs that stay in plasma affect vascular targets, like warfarin acting on clotting proteins. Drugs that enter tissue affect deeper targets, like digoxin in the heart. Examples: aminoglycosides poorly cross the blood-brain barrier, gives ineffective in brain infections and less inflamed. Tetracyclines bind to bone, gives used in bone infections like osteomyelitis. Effectiveness depends on drug location, not just dosage. Fat tissue accumulation and duration: lipophilic drugs are stored in fat tissue, which is low blood flow. They act fast by entering hyperfusion organs like the brain, then accumulate in fat, creating a slow-release depot. Example: thiopental is a fast-acting anesthetic, gives quickly, reaches the brain, then redistributes to fat, gives effect, ends fast, but drug stays longer in the body. This explains prolonged effects or toxicity, especially in obese patients or during repeated doses. Let's now summarize what we've learned about drug distribution. Drug distribution is more than movement. It's a fundamental part of pharmacokinetics that shapes how fast, how strong, and how long a drug works. Understanding distribution helps healthcare professionals, optimize drug dosing, predict clinical success, and avoid adverse effects. Now that we understand what drug distribution means and why it matters, let us explore the basic process of how a drug moves through the body after entering the bloodstream. Basic drug distribution process. Once a drug enters the bloodstream, it does not remain confined to the blood. Instead, it begins a dynamic journey through several biological compartments in a stepwise and organized manner. Let's break this down. Let's start with the first step, leaving the bloodstream and entering interstitial fluid. Step 1. Leaving the bloodstream. First, the drug exits the blood vessels and moves into the interstitial fluid. This fluid surrounds the cells and fills the space between them like a cushion that helps distribute nutrients and drugs. The ease with which a drug leaves the bloodstream depends on capillary permeability and blood flow to the area. Areas with more blood flow, like the heart, kidneys, and brain, get more drug delivered and quicker. Step 2. Entering individual cells. From the interstitial fluid, the drug may enter the cells themselves. This requires crossing cell membranes, a process that depends heavily on the drug's chemical nature. Lipid-soluble drugs pass easily through membranes, while water-soluble or charged drugs may need transporters or may be excluded entirely. Once inside, the drug enters the intracellular fluid, the site of many therapeutic actions. Now that the drug is inside the cell, let's explore what happens next. Step 3. What happens inside the cell? Within the cell, the drug may do several things. It might bind to receptors. This triggers its intended action. It might be stored temporarily in organelles or bind to intracellular proteins. In some cases, it may even be metabolized right inside the cell, especially in liver or kidney cells. All of these influence how long the drug stays active and how it is eventually eliminated. Finally, let's summarize the journey of drug distribution. So in summary, a drug starts in the bloodstream, moves into the interstitial fluid, and if conditions allow, crosses into cells to act on receptors or be stored. This movement is not random. It is guided by biological and physicochemical rules that determine where a drug will go, how fast, and how much. Understanding this pathway is essential for predicting a drug's onset, intensity, and duration of action in different organs. Before diving deeper into drug distribution, it is important to clearly distinguish it from other key pharmacokinetic processes. Each plays a distinct role in how a drug behaves in the body. Distinction of drug distribution from related concepts. Let's start with absorption. Absorption refers to the initial entry of a drug into the bloodstream. This usually happens after oral or other extravascular routes of administration. In simple terms, absorption describes how the drug gets into systemic circulation. Now, let's contrast that with distribution. Distribution begins after absorption or direct intravenous administration. It describes how the drug moves within the body from the bloodstream into tissues, organs, and body fluids. It describes how the drug moves within the body from the bloodstream into tissues, organs, and body fluids. Finally, let's look at metabolism and elimination. Metabolism is how the drug is chemically broken down, usually in the liver. Elimination refers to the removal of the drug from the body, mainly through urine or feces. These processes occur after distribution and determine how long the drug remains active in the system. Understanding these steps, absorption, distribution, metabolism, and elimination, and how they connect, is essential for predicting drug behavior and optimizing therapy. Drug distribution in the body is influenced not only by drug properties but also by the anatomical and physiological barriers that regulate movement between the bloodstream and tissues. Let's explore these barriers step by step. Anatomical and physiological barriers of drug distribution. First, we will discuss different types of capillaries. Under capillary types, there are three main types of capillaries that affect how drugs move out of the blood. Continuous capillaries are found in the brain and muscles. They have very tight junctions between endothelial cells, allowing only small molecules and lipid-soluble drugs to pass easily. This limits drug penetration especially in the brain, contributing to the blood-brain barrier. Fenestrated capillaries exist in organs like the kidney, glomeruli, and endocrine glands. These capillaries have small pores or fenestrations that allow moderate permeability, letting some larger molecules and water-soluble drugs pass through. Sinusoidal capillaries are found in the liver, spleen, and bone marrow. They have large gaps or fenestrations, making them highly permeable to even large molecules like proteins. This allows drugs easy access to these organs. Next, let's examine special physiological barriers designed to protect sensitive tissues. Special barriers. Certain tissues have unique barriers that restrict drug entry to protect vital functions. The blood-brain barrier (BBB) consists of continuous capillaries with tight junctions. Inactive efflux pumps like P-glycoprotein (PGP). This barrier prevents many drugs from entering the central nervous system (CNS), limiting exposure to protect the brain. The placental barrier separates maternal and fetal blood. Lipophilic drugs can cross easily to the fetus, but larger ionized drugs generally do not cross, helping to protect fetal development. The blood-testis and blood-retinal barriers protect reproductive organs and the eyes, respectively. Like the BBB, they restrict drug access to sensitive reproductive and visual tissues. Finally, let's look at how inflammation can alter these barriers. Inflammation effects. Inflammation can disrupt tight junctions in barriers like the BBB. For example, in meningitis, the inflammation loosens the blood-brain barrier, allowing drugs that normally cannot penetrate, such as ceftriaxone, to enter the CNS and treat infection effectively. Understanding these barriers helps explain why some drugs can or cannot reach certain tissues, influencing their clinical use. Once a drug enters the bloodstream, it must cross biological membranes to reach its target tissues. Several transport mechanisms are responsible for this movement. Let's explore each one and how it contributes to distribution. Mechanisms of drug distribution across membranes. 1. Passive diffusion. This is the most common mechanism for drug distribution. It occurs when a drug moves from an area of high concentration like the blood to an area of low concentration such as the tissues, without energy or carrier proteins. How it works. Lipid-soluble, small, and non-ionized drugs diffuse directly across cell membranes composed of lipid bilayers. Example, diazepam, a lipophilic benzodiazepine. Crosses cell membranes including the blood-brain barrier via passive diffusion. This allows rapid onset of sedation. Distribution relevance. Drugs that rely on passive diffusion tend to distribute more rapidly to tissues with hyperfusion and permeable membranes. 2. Facilitated diffusion. This is a carrier-mediated process where specific transporter proteins move drugs across membranes down their concentration gradient without using energy. How it works. A drug molecule binds to a carrier protein on the membrane surface, which changes shape and transports the drug into or out of the cell. Example, glucose is transported into cells using GLUT transporters, and some structurally similar drugs may exploit similar transport pathways. Distribution relevance. Facilitated diffusion helps certain drugs reach tissues even if they are not lipid-soluble, especially important in tissues like the brain, where passive diffusion may be limited. 3. Active transport. This mechanism uses energy, usually ATP, to move drugs against their concentration gradient using specialized transport proteins. How it works. The cell actively pumps the drug into or out of tissues. This can either enhance tissue uptake or prevent accumulation. Example, levodopa, used in Parkinson's disease, is transported across the blood-brain barrier by LAT1 L-type amino acid transporter 1. Without this transporter, levodopa could not effectively enter the brain. Distribution relevance. Active transport is essential for delivering drugs to protected sites like the central nervous system or the placenta, and for drug accumulation in specific tissues. 4. Endocytosis and pinocytosis. These are energy-dependent processes where the cell membrane engulfs the drug into a vesicle and brings it inside the cell. Endocytosis, used for larger molecules like proteins or complexes. Pinocytosis, refer specifically to uptake of fluids and solutes. Example, iron binds to transferrin, a protein that interacts with receptors on the cell surface. The complex is internalized via endocytosis into cells such as those in the bone marrow or liver. Distribution relevance. Although rare, this mechanism is crucial for distributing large, complex molecules like monoclonal antibodies, vitamin B12, and liposomal drugs into target tissues. Summary. Each transport mechanism contributes differently to drug distribution. Passive diffusion handles most small, lipophilic drugs. Facilitated diffusion and active transport help move hydrophilic or large molecules where needed. Endocytosis allows certain complex drugs to reach specific target sites. Understanding these mechanisms helps in designing drugs and predicting their tissue penetration and therapeutic effects. Drug distribution is a complex process influenced by several factors. Understanding these helps predict where and how a drug acts in the body. How factors influence drug distribution. Let's examine each factor with examples. Physicochemical properties. 1. Lipid solubility. Drugs that dissolve well in lipids cross cell membranes more easily and distribute widely into tissues. Example, diazepam is highly lipophilic, so it rapidly crosses the blood-brain barrier and accumulates in the brain, making it effective as a sedative. 2. Molecular weight. Large molecules have difficulty crossing capillary walls and cell membranes, restricting their distribution. Example, heparin is a large molecule that stays mainly in the bloodstream, limiting its distribution to plasma. 3. Ionization pKa and pH. The degree to which a drug is ionized depends on the local pH. The drug's pKa. Non-ionized and charged forms cross membranes easily, while ionized forms cannot. Example, aspirin, an acidic drug, is non-ionized in the acidic stomach environment, promoting absorption, but becomes ionized in blood, limiting its crossing back. 4. Protein binding and drug distribution. When a drug enters the bloodstream, it doesn't circulate freely. Instead, much of it binds reversibly to plasma proteins, a key factor that limits its distribution, activity, and elimination. Key plasma proteins and their roles. 1. Albumin, the most abundant plasma protein in the blood. Synthesized in the liver. Binds primarily to acidic drugs. Acts like a temporary drug reservoir, releasing drugs slowly as free levels drop. Examples of drugs that bind to albumin: warfarin, phenytoin, aspirin, valproic acid. 2. ALPHA1 acid glycoprotein AAG, an acute phase reactant produced by the liver. Increases during stress, inflammation, trauma, and cancer. Binds mainly to basic drugs. Examples of drugs that bind to AAG: lidocaine, propranolol, imipramine, morphine. 3. Globulins, a group of plasma proteins that may bind to specific hormones or vitamins. Also include lipoproteins that can bind lipophilic drugs. Less commonly involved in albumin or AAG. Example, corticosteroids bind to transcortin, a type of globulin. Why is protein binding important? Only the unbound free drug is able to cross membranes into tissues available for metabolism and elimination, capable of interacting with receptors to produce effects. Bound drug acts like an inactive reserve, circulating in plasma but not contributing to therapeutic or toxic effects until released. Levels of protein binding high, greater than 90%. Very little free drug. Small changes in protein levels gives big changes in effect. Moderate 60 to 90%, somewhat buffered. Still affected by binding shifts. Low 60%. Most of drug is free. Less affected by binding changes. Examples: by binding level, warfarin, highly bound, greater than 97%. 2. Albumin gives narrow therapeutic index. Phenytoin, approximately 90% bound, gives sensitive to albumin changes. Theophylline, approximately 40% bound, gives more consistent effect. Lithium, negligible protein binding, gives plasma concentration. Reflects total drug clinical relevance of protein binding. 1. Hypoalbumin AG, liver disease, malnutrition. Albumin equals free drug. Risk of toxicity even if total drug levels appear normal. Example, in low albumin, phenytoin becomes more free, give seizure control may improve, but risk of side effects rises. 2. Acute phase reactions, AAG equals more basic drug bound gives free drug may need higher dose to achieve effect. Example, propranolol in sepsis may bind more to AAG gives less drug available, gives reduced efficacy. 3. Drug-drug interactions, one drug can displace another from protein binding sites. This increases free concentration temporarily, gives possible toxicity. Example, sulfonamides displace warfarin gives increased bleeding risk due to more inbound warfarin. 4. Dialysis considerations, only free drug is dialyzable. Highly protein-bound drugs are not effectively removed during dialysis. Example, phenytoin is not significantly removed by dialysis, gives dosing doesn't change much. Summary: albumin binds acidic drugs, AAG binds basic ones. Only free drug is active. Only free drug is active. Changes in protein levels due to disease or interactions must be considered when adjusting doses or interpreting lab values. Blood flow to tissues. Tissues with higher blood flow receive drugs more rapidly and in larger quantities. Hyperfusion organs, heart, liver, kidneys, and brain receive a large fraction of cardiac output, so drugs reach these sites quickly. Example, after injection, lidocaine quickly reaches the heart and brain due to high blood flow. Low perfusion tissues, fat, bone, and skin have low blood flow, so drugs reach these sites more slowly. Example, lipophilic drugs may slowly accumulate in fat, prolonging their effect. Tissue binding and affinity. Some drugs have a special affinity for certain tissues, causing accumulation and extended duration. Example, tetracyclines bind to calcium in bone, leading to accumulation and possible discoloration in teeth and bones. Example, chloroquine accumulates in the liver and spleen, which affects its dosing and toxicity profile. Transport proteins. Membrane transporters can pump drugs into or out of cells, affecting distribution. Example, P-glycoprotein PGP pumps many drugs out of brain cells, limiting central nervous system exposure, which is why some drugs cannot effectively treat brain infections. Example, organic anion transporters. Oats in the kidney help remove drugs like penicillin, affecting how long they remain in circulation. Pathophysiological states. Disease states and physiological changes alter drug distribution. Edema and ascites increase extracellular fluid volume, diluting water-soluble drugs and lowering effective concentrations. Example, in ascites, water-soluble antibiotics may require higher doses. Cachexia, loss of muscle mass reduces tissue-binding sites, potentially increasing free drug levels. Hypoalbuminemia, reduced albumin means less protein binding, more free drug, and increased toxicity risk. Example, in liver disease, free phenytoin levels rise despite normal total plasma levels. Understanding these factors helps clinicians adjust dosing and predict therapeutic outcomes more accurately. Understanding drug distribution involves not just concepts but also key quantitative measurements. These calculations help predict drug behavior in the body and guide dosing decisions. Understanding drug distribution involves not just concepts but also key quantitative measurements. These calculations help predict drug behavior in the body and guide dosing decisions. One volume of distribution, abbreviated as V, volume of distribution, is a key pharmacokinetic concept. It helps us understand how a drug spreads within the body. VD is defined as the amount of drug in the body divided by the plasma drug concentration. A small VD means the drug stays mostly in the plasma, for example warfarin. A large VD means the drug moves into body tissues, for example amiodarone. Knowing the VD helps guide proper dosing and shows how widely a drug is distributed. Let us look at an example of volume of distribution, or VD. A 500 mg dose is given by intravenous bolus. The resulting plasma concentration is 10 mg per liter. To calculate VD, we use the formula VD equals dose divided by plasma concentration. So 500 mg divided by 10 mg per liter gives us 50 liters. This means the drug distributes widely into body tissues as indicated by the large volume of distribution. Number to loading dose. Loading dose is abbreviated as LD. It is calculated using the formula LD equals CP times VD. CP stands for the target plasma concentration. Loading dose is used when a rapid therapeutic effect is needed. It is especially important for drugs like digoxin. This is most useful for drugs with a large volume of distribution or long half-lives. Let us go through a clinical example of loading dose. A 70 kg patient requires drug X. The target plasma concentration is 5 mg per liter. The volume of distribution is 2 liters per kilogram. To calculate the loading dose, we use the formula LD equals CP times VD times weight, that is 5 mg per liter times 2 liters per kilogram times 70 kg. The result is 700 mg. 3. Free fraction, also known as FU, refers to the inbound portion of a drug in the bloodstream. It is calculated as the free drug concentration CF plus the total drug concentration CT. Only the free drug is pharmacologically active. Drugs with a low free fraction such as phenytoin are highly protein-bound in patients with hypoalbuminemia, low albumin levels. Careful monitoring of drug levels is critical to ensure both efficacy and safety. Clinical example, free fraction FU. The patient has total phenytoin concentration 15 mg per liter. Free phenytoin concentration 1.5 mg per liter. To calculate free fraction FU, divide free concentration CF by total concentration CT. 1.5 divided by 15 equals 0.1, or 10%. Interpretation, only 10% of the phenytoin is inbound and active. In patients with hypoalbuminemia, low albumin levels, the free fraction may increase. This can lead to greater drug effects and higher risk of toxicity. Close monitoring is required in these cases. For distribution half-life, the distribution half-life describes how quickly a drug spreads between blood and body tissues. It's calculated using a simple but important equation. The equation is 0.693 divided by the sum of K1, 2 and K2. Let me explain what these terms mean. K12 is the rate at which drugs move from blood into tissues. K2 is the rate at which drugs return from tissues to blood. When this half-life is short, drugs act very quickly. A classic example is thiopental, which works almost immediately because of its extremely short distribution half-life. This measurement is especially valuable in critical care situations. It helps medical teams determine exactly when a drug will take effect. Time doses properly for maximum benefit. Avoid potential overdose risks. Key thing to remember is that distribution half-life tells us about a drug's movement through the body, while elimination half-life tells us how long the drug stays in the body. This understanding is crucial when working with fast-acting medications in emergency settings. Distribution half-life example. Given values, the rate constant K12 equals 0.4 per hour. The rate constant K21 equals 0.6 per hour. Calculation, define the distribution half-life. First, sum the rate constants. 0.4 plus 0.6 equals 1.0. Then divide 0.693 by 1.0. This gives a distribution half-life of 0.693 hours. Clinical interpretation, this short half-life indicates a rapid distribution phase, meaning the drug reaches tissues quickly. A well-known example is thiopental, which acts within seconds due to its fast distribution. 5. Henderson-Hasselbalch equation and drug absorption. The Henderson-Hasselbalch equation describes how drug ionization affects absorption. Let's break it down. The equation states pH equals pKa plus the log of the ratio between ionized drug and non-ionized drug. This matters because ionization determines membrane permeability. Shard drug molecules cannot easily cross cell membrane as neutral molecules pass through more easily. Weak acid drugs absorb be better in acidic environments like the stomachs. Loaf because more drug remains in the neutral, absorbable form. This has critical implications for drug design. Scientists adjust molecular properties to optimize absorption, therapeutic effectiveness, where and how well drugs get absorbed. Safety, preventing improper absorption that could cause toxicity. Classic example is aspirin. As a weak acid, it's well absorbed in the stomach because the acidic environment keeps it neutral, allowing it to cross into the bloodstream. Understand this equation helps predict where drugs will be absorbed in the body, how pH changes might affect medication absorption, how to design better pharmaceutical compounds. Clinical case, aspirin absorption. Let's examine how ionization affects aspirin absorption in the body. Key facts: aspirin is a weak acid with a pKa of approximately 3.5. The stomach has a strongly acidic pH of about 2. Blood pH is more alkaline at 7.4. Critical question: where does most aspirin absorption occur and why? The answer: Aspirin is primarily absorbed in the stomach. Here's why. In the stomach's acidic environment pH 2, aspirin remains mostly in its non-ionized form Ha. This neutral form can easily cross cell membranes. Once absorbed and entering the blood pH 7.4, aspirin becomes more ionized, trapping it in circulation. Clinical significance. This explains why aspirin works quickly when taken orally. Antacids might slow its absorption by raising stomach pH. Understanding pH and ionization helps predict drug behavior. 6. Tissue-to plasma partition coefficient Kp. The tissue-to plasma partition coefficient, called Kp, is a key pharmacokinetic parameter calculated as drug concentration in tissue divided by drug concentration in plasma. What this tells us, high Kp values like propranolols indicate significant drug accumulation in tissues, create potential drug reservoirs that prolonged effects may increase risk of delayed toxicity. Clinical implications. Helps predict drug distribution patterns. Explains why some drugs have long durations of action. Warns of potential tissue-specific toxicity risks. Practical examples. Fat-soluble drugs accumulate in adipose tissue. Basic drugs often concentrate in lysosomes. Heavy metals may deposit in bone or liver. With this matters. Understanding Kp helps clinicians anticipate drug interactions. Suggest dosing for patients with large tissue masses. Monitor for tissue-specific adverse effects. Tissue-to plasma partition coefficient example. Let's examine a real-world calculation using propranolol. Given values: plasma concentration 2 mg per liter, tissue concentration 20 mg per liter. Calculation: Kp equals tissue concentration divided by plasma concentration 20 divided by 2 gives a Kp value of 10. Clinical interpretation. This high Kp value shows propranolol strongly accumulates in tissues, about 10 times more than in blood. Practical implications. Creates a drug reservoir that slowly releases back into circulation. Explains propranolol's long duration of action may increase risk of tissue-specific toxicity with prolonged use. Of monitoring considerations. Patients with large muscle mass may store more drug. Dose adjustments may be needed and obesity effects may persist after stopping medication. Summary of key distribution parameters. Let's review the essential pharmacokinetic parameters that guide drug therapy. Volume of distribution (VD) predicts how widely a drug spreads in the body. Helps determine loading dose. Loading dose (LD) calculates initial dosing to achieve rapid therapeutic levels. Free fraction (FU) measures active and bound drug concentrations. Critic for highly protein-bound drugs. Distribution half-life T1/2 alpha determines how quickly drugs reach tissues. Affects onset of action. Thin PKA relationship governs drug absorption and ionization. Explains site-specific absorption patterns. Tissue-to plasma partition coefficient Kp reveals drug accumulation in tissues. Predicts duration and potential toxicity. Clinical value. Together, these parameters enable precise dosing prediction. Separate personalized treatment plans help minimize adverse drug effects. Final takeaway. Mastering these concepts allows clinicians to optimize therapeutic outcomes. Suggest for patient-specific factors. Enhance medication safety. Drug distribution kinetics models and clinical implications. Understanding how and where drugs go in the body. Drug distribution models. One compartment model. This model assumes instant distribution. Drugs spread uniformly throughout the body immediately after dosing. Single compartment. The body acts as one unified space. Best for drugs like gentamicin because of rapid, even distribution in blood and fluids with minimal tissue accumulation. Key advantage: simplifies dosing calculations for clinicians. Limitation: less accurate for drugs storing in fat or tissues. Two-compartment model. This model divides the body into two parts. The central compartment includes blood and highly perfused organs like the liver and kidneys. The peripheral compartment contains slower tissues like fat, skin, and muscle. Drug levels show two distinct phases. The alpha phase represents rapid drug distribution between compartments. The beta phase reflects slower drug elimination from the body. This model provides more accurate predictions for most drugs compared to the one-compartment approach. Drug redistribution. Explain drug redistribution occurs when medications move from their initial target site into other body tissues. This process is especially important for drugs that act quickly in the central nervous system. A classic example is thiopentol, an anesthetic that produces rapid effects but short duration. Here's why. It first reaches the brain, causing immediate anesthesia, then quickly moves into fatty tissues and muscles. This redistribution away from the brain makes the effects wear off fast. This phenomenon and is particularly relevant for fat-soluble medication. Central nervous system drugs. Rapid-acting anesthetic sudden redistribution helps explain why some strong medications have surprisingly short durations of action. Clinical implications of drug distribution. One impact of disease states on drug distribution. Diseases can significantly alter how drugs move through the body. Liver disease. Reduced albumin production leads to more free active drug. Example, warfarin becomes more potent in cirrhotic patient chart. Failure rapport. Circulation changes a drug's volume of distribution. Example, digoxin requires careful dosing adjustment. Renal disease. Accumulated toxins displace drugs from proteins. Example, phenytoin. Toxicity risk increases in kidney failure. Key clinical takeaway. Always consider a patient's disease state when prescribing medications that are highly protein-bound or have narrow therapeutic windows. To drug interactions affecting distribution. To key mechanisms can alter drug distribution. Protein binding displacement. On medication pushes another off blood proteins. Example, sulfonamides increase free warfarin levels. This raises bleeding risk. Dermatocalitroniders. Competition drugs fight for the same tissue pathways. Example, verapamil boosts. Digoxin. Heart concentrations can lead to dangerous arrhythmias. Interactions are especially critical for medications with narrow safety margins. Drugs that are highly protein-bound. Cardiac and neurological treatments. Always check for distribution interactions when prescribing multiple medications. 3. Therapeutic drug monitoring. TDM. Therapeutic drug monitoring, or TDM, involves measuring drug levels in the blood to ensure they stay within the optimal therapeutic range. Key points. Purpose: maintain drug levels that are effective but not toxic. Common examples: phenytoin for seizure control, digoxin for heart conditions. Clinical benefit: helps balance effectiveness and safety, especially for drugs with narrow therapeutic windows. TDM is essential for medications where small changes in concentration can lead to serious side effects or treatment failure. For drug distribution in special populations, important considerations for different patient groups. Neonatal body water content increases volume of distribution for water-soluble drugs. Example, gentamicin requires adjusted dosing in newborns. Elderly patients. Increased fat stores and decreased albumin altered drug distribution. Example, diazepam effects last longer due to fat accumulation from women. Expanded blood volume and reduced albumin change drug behavior. Example, antipileptic drugs need close monitoring during pregnancy. Takeaway: always consider population-specific factors when prescribing medications to ensure safety and effectiveness. Examples of drug distribution patterns. Key drug distribution patterns. Let's examine 6 clinically important examples. Digoxin high volume of distribution constant in heart and muscle. Tiswefinitional volume of distribution sties mostly bound to blood protein. Thiopenthal volume of distribution rapidly redistributes into fat stores. Warfarin volume of distribution premi circulates in plasma. Lithiumentary volume of distribution spreads evenly through body water. Gentamicin volume of distribution limited to extracellular fluid. Clinical insight: these patterns directly impact dosing, monitoring, and toxicity risks for each medication. Summary and integration. Drug distribution overview. Drug distribution is governed by 4 key factors: drug properties like solubility and molecular size, superfusion rates, protein binding levels, biological barriers e.g. blood-brain barrier. Critical pharmacokinetic parameters include volume of distribution (VD), predicts drug spread. Partition coefficient (Kp), measures tissue accumulation. Density. Half-life T1 half alpha, tracks equilibration speed. Clinical considerations: patient-specific factors, age, pregnancy, diseases, drug interactions altering distribution. This matters. These principles guide accurate dosing regimens. Therapeutic effectiveness. Toxicity prevention. Summary of drug distribution. Understanding drug distribution is critical because safety and efficacy It determines whether a drug reaches its target effectively without causing harm. Action timeline predicts how quickly a drug works onset, how long it lasts duration, and where it acts in the body. Personalized medicine enables tailored dosing based on patient-specific factors like age, disease, and genetics. In clinical practice, this knowledge helps optimize therapy while minimizing risks. Thank you for learning with the PharmaconHealth Pharmacology series. We bring you clear, science-based explanations of how drugs work in the body. Our content bridges classroom knowledge with clinical practice, helping you understand drug mechanisms and therapeutic principles. Subscribe to explore more episodes covering how drugs work at the molecular level, practical clinical applications. Key pharmacology concepts. Keep building your knowledge. Stay updated with the latest science and continue mastering pharmacology with us.